There it is. Now it's working. All right, so talk about suctioning. There are, this is from the ARC's clinical practice guidelines, but in order to maintain a patent airway, you may need to remove secretions or other stuff that is there if the patient is unable to do it by themselves, or even though they do their best effort to clear the airway, it's not able to be cleared. So we can physically clear it ourselves using nasotracheal oral tracheal suctioning. Three different types of suctioning that we're going to encounter. And we'll talk briefly about each of them. Suctioning of the oral cavity doesn't get anything further down than just what's in the oral pharynx. Nasotracheal suctioning, which is through the nasal pharynx and also to some extent into the hypopharynx. You technically can access the trachea, but it's very difficult to. And then finally, through an artificial airway, where the airway is placed into the trachea, we can go ahead and pass a catheter and suction out the trachea. First, it's going to start with an assessment. We want to be able to find out through multiple ways whether or not there is secretions that need to be cleared. Sometimes you can hear the rhonchi without even having the stethoscope placed on the chest. There's a gurgling, what used to be called the death rattle. In fact, rhonchi, I believe, is French for rattle. I could be wrong on that, but we can also do rhonchal or bronchial fremitus. Fremitus implying that I'm placing a hand on the chest, and in doing so I can feel the vibrations of those secretions in the larger airways. Sometimes you can see it visually. If their patient has an endotracheal tubing, you can see the secretions coming up the tube. And also just the weak or ineffective cough we had talked about previously. And again, all those, the fact that the secretions are there probably is meaning that there has some impedance to adequate oxygenation, adequate ventilation, so you may see signs of increased work of breathing and a response by the heart to speed up due to the hypoxemia. So what equipment do we need? Well, we need a vacuum source that has an adjustable pressure regulator. Something that looks like this. So I can adjust, and on this there's two settings. There is a continuous setting, and then there is an intermittent setting. For our purposes, we're always going to use the continuous setting. If you got a nasogastric tube, they would use the intermittent. And then there's a control to regulate what vacuum pressure you want to be able to utilize. There's not a PE on this for this course, but there is for 1260. So over the summer, there'll be a performance evaluation where you'll have to, there's actually a few of them, but you'll have to use a suction kit to go ahead and suction out a source. Then there's also going to be a collection container and connecting tubing, so running from the vacuum source to a collection bottle, which periodically, obviously, is going to get full and needs to be emptied. Your sterile suction kit's going to have a couple things in there. They'll have the catheter itself, and we're going to determine what size catheter in a few minutes. But there's specific sizing depending upon the size of the airway you have. Beside the catheter, there's typically disposable gloves, sometimes one, usually two. And there's usually a small collapsible little water cup that you can use to fill to rinse the catheter out. And we'll talk about that process. If you plan on irrigating the airway as far as the endotracheal tube, there's some normal saline you can use. It's controversial whether or not it does anything, but for the case of a nasotracheal suction, you also want to have some water-based lubricant because I'm putting it through the nasal passage. I want to end up having something that makes it slide in easier. Notice it says water-based, never petroleum-based. Okay. Sometimes a local anesthetic might reduce the discomfort of the catheter passage. Better option is to use what we call a nasopharyngeal airway, and we'll talk about that next time. I'll always want to have resuscitative equipment handy. In an acute care setting, we'll probably have the patient on an EKG monitor along with a pulse oximeter and obviously personal protective equipment for us. Here's an example of some of the vacuum regulators. Like I said, the ones that pop into the wall. They actually have portable units also. So if you're on a transport, you can end up using that portable suction system. And those are the regulators, and those are the canisters, the collection canisters, and the connecting hose to go from one to the other. Different types of catheters here. We'll talk about these each individually. But on the left-hand side, you can see the Yankauer, or rigid tonsil suction. It's used to suction out the oral pharynx. It may or may not have a control button there in the center. It may just be that it's continuously on. Then there's a standard flexible suction catheter. And then there's a multi-use closed system suction catheter, and we'll talk about those a little bit here, but also in over the summer. Most of the suction catheters are designed so they have multiple ports, and the reason being is if this port that is the primary port right here gets pulled up against the wall of, or is pushing up against the wall of the airway, you don't want there to not have any suction there. That'll cause some trauma to that area. So we're going to have alternate areas that the vacuum can still pull through without necessarily pulling against the mucosa of the tracheal wall. Specialized catheters that you should know. The first one is called the Coude, also known as a bronchotract left, and it's designed, it's bent so that as it's going down, it's designed to go into the left main stem bronchus. Remember, the left main stem is not as acute as the right main stem, so when we want to get into the left side, we would end up using a Coude catheter. And there's some other ones there to reduce trauma. There's more designs than there are catheters. I shouldn't say that, but every catheter has its own little uniqueness to it. But generally speaking, the Coude is the one that you should know about. Then what if I want to get a sample of my suction, whatever I'm suctioning out of the lungs, to send down to the lab to be able to be analyzed? There are what are known as a Lucan sputum trap, which basically is placed in between. This is usually the design. I haven't seen that design in the other design in a long time, but the one on the lower right is basically placed in between the vacuum source and the catheter. Then once we collect some secretions, that is then detached, and we send it off and process it with the lab. One of your PEs will be doing open suctioning with getting a sputum sample. It's a little bit interesting because I have to manipulate detaching and attaching the tubing with one hand because the other hand is sterile. So it's a little bit fun, to say the least. This is one I don't know that they're still around or not. If they are, I would never want to use it. But this is what we used to use in the delivery room to clear the airway, even if it's not fully out of the out of mom. But the catheter here would go into the baby's airway to clear out the oral pharynx, nasal pharynx. Anybody want to make a guess what this end hooks up to? The caregiver's mouth. The vacuum is created. I don't think so. I'm not on that list. All right. Some of the catheters will have depth markings so you know how far you're going in. And the most common complication of suctioning is trauma, or one of the more. So oral suctioning, let's start there. I just want to clear out the oral cavity. I'm going to have my Yankauer or tonsil suction. I'm going to have my vacuum source, my collection container. My regulator is going to be set. I may have some normal saline or normal sterile water. The little cupper basin so I can clear stuff out. And then whatever PPE is available. So it's attached in this fashion. And this is the catheter itself. It may have a thumb control. It may not. The tip of it usually is very large, so it's going to remove large amounts and large particles. And we'll do a demonstration on it. We'll save that for the summer. So, want to go ahead and put on my personal protective equipment, including non-sterile gloves and goggles, or a fluid shield, so that if something gets splashed, it doesn't come up on me. Fill my basin with sterile water. I'm going to attach the Yankar suction catheter, keep it in the package. I'm going to test the system by placing the suction catheter into the water to make sure it's functioning. And then I'm going to go ahead then and set my vacuum to the proper level. This is something you don't need to know the millimeters of mercury, but you should know, or inches of mercury, excuse me. You should know millimeters of mercury. I'm sorry, you do need them. So minus 100 to minus 120 for an adult, minus 80 to minus 100 for a child, and minus 60 to minus 80 for an infant. I would begin the process of committing those to memory, because you're going to be asked them over and over and over again. Now, the ARC's Clinical Practice Guidelines does say that a maximum of 150 can be used if the 120 is ineffective, but for our purposes, minus 100 to minus 120 for a adult. We're going to go ahead then and inform the patient of what we're going to do and position them. We're going to monitor them throughout the procedure to make sure there's no adverse effects. I'm going to apply the vacuum and pass the catheter into the patient's mouth and across the back of their throat, so we're clearing out, just like the dentist office, that kind of a process. If they close their mouth around the catheter, they can get a little bit better vacuum in clearing it out. And I'm going to rinse it and repeat as necessary. Once we're done, we'll go ahead and put the catheter back in the wrapper so we can store it. There's all kinds of other devices that are out there to prevent them from being contaminated. Turn off my vacuum, and we're going to change that catheter on a daily basis, or when they really look icky. And we're going to dispose of the equipment properly, ideally in a biohazard, because this is something that has patient secretions. Sucking the breath out of you since 1960. Ain't that the truth? So about nasotracheal suctioning. I want to pass a catheter through the nasal passage into the hypopharynx to be able to suction them out. Same kind of stuff as on the left-hand side as far as the equipment that is necessary. The difference being is that we're going to have our sterile suction kit now. They come in various sizes and lengths. They may have more than one or just one opening. It depends really on the catheter's design. There's going to be a thumb port that, when with the thumb port is occluded, vacuum is applied to the end of the tip. Make sure that it's maintained sterility, and I have some monitoring stuff available. And again, we'll talk about a nasopharyngeal airway. If you're doing repetitive nasotracheal suctioning, it makes sense to put a nasopharyngeal airway in it and just pass it through that airway as opposed to running it through the person's nose each time. So again, the design is I have my vacuum hooked up to the connector, and as I put my thumb over the end of the thumb control valve, vacuum is applied at the very tip, and we can apply it to the airway. So here's the sterile suction kit. The key part here is when you're opening the kit and placing and putting the gloves on and whatnot, that all has to be in a sterile fashion. So once you touch something on the inside, it better be a sterile glove that you're using to touch that spot. And you'll get really, really good at maintaining sterility, because Amber and Lori will beat it into you if not. Sterile. So the nasopharyngeal, really that passage is not sterile, but we try to maintain as much clean technique as we can, ideally as a sterile setup. When we're talking about actually going into the trachea, that has to be sterile, because the normal function of the upper airway is to protect, and if I bypass that by putting an airway in, now I need to maintain sterility. Okay. So you're going to take a look at the catheter size, make sure it's the right size. Your kit may or may not have more than one holes at the very tip. Usually there's 2 sterile gloves, and usually the size of the glove is a universal, one size fits all, but we'll get by with it. Sometimes there's a sterile field that you can create. Sometimes there's a basin, and rinse solution usually is an other type. You can see the different designs that are there. You don't need to know the different names for them aside from the coude. I do want you to know that one. But there's just different manufacturers with different designs, and they'll claim that one is better than the other. Contraindications, the only absolute contraindication is epiglottitis. I think Lori talked about epiglottitis before, and stay as far away from that airway as you can. But other things like occluded nasal passage, deviated septum, nasal bleeding or bleeding disorder, patients who are in laryngospasms wouldn't want to do it, somebody who has perhaps a hyperactive airway, some head or facial injury, or some infections. And there are a ton of complications, trauma probably being one of the most common ones. Although I also would say hypoxemia is probably one of the more common ones also. Because I'm sucking the air literally out of somebody, the potential for their oxygen levels to deteriorate is quite great, which means you can have all kind of other side effects secondary to that. You can have tachycardia because of the hypoxemia. You can also have bradycardia because of a vagal stimulation. So it goes both ways. Cardiac arrest, respiratory arrest, well, this sounds like a real wonderful thing that we are doing here. It shouldn't be taken lightly is the key part. And some of the other ones noted there, including infection and atelectasis twice. Why atelectasis is there twice, I have no idea, but it is. And then it's going to increase your intracranial pressure. So what we're going to do, wash our hands, put on our PPE, put the patient into the Fowler's position with the head and neck extended, what we call the sniffing position. When you're making chicken soup and you want to smell it, what do? You flex your head forward. That's called the sniffing position. We'll find that's a position that we use when we're trying to intubate somebody also. Monitoring their oxygen, apply oxygen if needed. Ideally, we would like to pre-oxygenate the patient for at least 30 seconds. Most sources say as much as 2 minutes. If they don't have oxygen, have them just take some deeper breaths. And I'm going to turn on the suction with the tubing being occluded. So I'll take and I'll adjust my suction with the vacuum turned, with the tubing occluded. Set it to the appropriate level, 100 to 120 of vacuum for the adult. Open my sterile water. Open my water-soluble lubricant if needed. Open my kit. Again, this is all maintained the sterility. Put on the sterile gloves. There's a sterile drape, laying that out. Opening the basin. Place catheter in the dominant hand, using the non-dominant hand that is now non-sterile to be able to do things like fill the basin with sterile water, attach a suction tubing, and if there's lubricant being used, squirt that into the sterile package. Test the catheter by placing it in the saline and applying a little bit of vacuum. If you're going to use the lubricant, it's time to lubricate it. Monitor my patient, and I mentioned that there's some bad things that can happen. I think I did, like them dying. Okay. You want to monitor all these various parameters. Hold the catheter near the tip. One of the biggest mistakes I see students doing is they're holding the catheter with the catheter just dangling there. The closer you have it you're held, the closer to the tip you are, the better control you have over it. When you are writing, nobody writes like this, right? A page may, I don't know. We have our fingers as close to the tip as possible so that you can, thank you, so that you can end up having better control over it. You can have them stick out their tongue. It's not really necessary, but might allow the passage into the pharynx a whole lot easier. Do not apply suction while the catheter is being inserted. We only apply vacuum on the way out. Pass the catheter gently and continuously along the nasopharynx until you get to the hypo or oral hypopharynx. Then withdraw the catheter if they begin to gag or vomit. And this is how I want the patient positioned. Now notice if you have them in that position, there is the possibility that the catheter could enter into the trachea. Not very common, but you can end up doing it, especially if you advance the catheter when they're taking a breath in. So they exhale, then they inhale. I'm advancing the catheter at that point, because at that point your glottis is open, and you can actually pass it into the trachea. Once it passes through, let's see what this is just showing. In the sniffing position, they're advancing it, and we actually get it in. Once you get it into the trachea, they're going to start coughing. At that point, then you can apply vacuum. If you're meeting any obstruction, do not force it. You can try rotating it, especially as it's passing through the nasopharynx. If they got a deviated septum or nasal polyps, you might meet some resistance, so just a little rotation of the catheter allows it to pass, or try the other side. Continue to pass into the trachea. If the patient, ask them to take slow, deep breaths, but not swallow, because you don't want the catheter going into the esophagus. And then if they begin coughing, withdraw the catheter a little bit, and then go ahead and apply intermittent suction pressure by placing your thumb over the port, 10 to 15 seconds for the duration of time that you're in that airway, no more. Remove the catheter, rinse it, try to suction again if needed, and finally suction the mouth after the whole procedure so that there's any secretions in the mouth that they're taken care of also. Post-oxygenate at least for a minute, perhaps even longer. And if you're going to do it repeatedly, consider putting a nasal airway in. And we'll talk about that next time, as I've said. Once we're done, dispose of everything, turn off the vacuum, reassess the patient, reevaluate the need for oxygen, reposition them, get rid of your PPE, and document it. And the poor dog. And that's it, right? All right. Questions?